So welcome to this evening's Health and Information Talk organised by the Governors of University Hospitals of Derby and Burton. My name's Val Haylett. I'm one of the Governors for City of Derby. I'm also Chair of the Members Engagement Group, which is why we're all meeting tonight. I hope you enjoyed the pre-meet information tables. Seemed to have a bit of a buzz going in there. It seemed very busy. Housekeeping first. In the event of a fire alarm, which we're hoping won't happen, the emergency doors are at the back of the room and at the side of the room. It's my hostess a little bit there. I must apologise. The BSL interpreter hasn't been able to make it tonight, and so we haven't got one. I'm sorry about that. The talk this evening is being recorded and will be on the UHDB website in the next week or so. And if you wish to watch it again or share it with friends, colleagues, family, because it's a really interesting talk, that would be really good. There will be time at the end of the talk for questions. So anyone joining on Teams can actually put their questions in the chat bar. We will get that. And I'll go around the room with the microphone. No further ado, I'd like to introduce Jeff Bevan, who's going to be our wonderful speaker for this evening. Thanks, Jess.
Thank you very much, Val. Can everybody hear me? No? Somebody's saying no. I'll try and keep close to the mic and speak as slowly and as clearly as possible. There is 2 seats at the front, so if your hearing's not so good, coming to the front is absolutely fine. Nobody likes the front row, do they? So my name's Jess Bevan. I'm one of the stroke consultants that works here at UHDB in a very busy stroke service, and I see the consequences of hypertension. So my view is a little bit different than your general practitioners, and my approach to hypertension is a little bit different because of the urgency of controlling hypertension after stroke. So I'm hopefully going to tell you a little bit about high blood pressure, what you can do about your blood pressure for your health, why it's a problem, and why it's quite difficult to control your blood pressure. So often people will say, you just need to be less than this number, but it's not that straightforward. So this is what we're going to talk about. Hypertension, why is it a problem? What is hypertension? What's normal? And how do you measure it? How do you treat it? And then I've got a little bit of take-home advice. And the little summary take-home advice is also on a little handout over there with a little box for you to put your own blood pressure recordings on as you go home. So high blood pressure is an increasing problem. And if you look at worldwide, hypertension is a massive problem affecting billions of people. And most people who've got hypertension aren't even aware they've got it. Now, if we could treat that hypertension, we might prevent a huge number of strokes, of heart attacks, of kidney disease, people needing dialysis. And the burden of hypertension is worldwide. Now, in the UK, we're lucky that we have access to treatments, but in other areas of the world, it's much more difficult to access treatments. And what we've found is that actually when you look at how common hypertension is, actually the number of hypertension that we see in people that we measure now has actually doubled over the last 20 years. So more people at younger ages are getting hypertensive. And that's a reflection really of our lifestyle and the changes in what happens and what we do to our bodies. But it's also because we all live a lot longer. So this graph shows you a little bit of what the burden of hypertension is worldwide. Now, if you look in different countries, you'll find that hypertension is more common in different countries and is a greater burden. And that gives you a little bit of a view of what is the underlying genetic cause of hypertension as well as lifestyle. So you can see that, as you might expect in less developed countries, that there is a lot of hypertension that's not even known about because nobody will even have access to anything to measure their blood pressure. The first time they might know is when they die from a massive stroke, or they might never know in their whole life when they die of something else like a road traffic accident or similar. But if you look in the high-income countries, you can see that there's more identified hypertension, but actually it's still quite undertreated. And we'll come on to the reasons for that and why that might be happening. And some of you have already talked a little bit to me today about about how difficult it is to know what to do about your blood pressure. So we said it's easy, it's about numbers, isn't it? So this is the current guidance and definition of what high blood pressure is. So when you look at this, you start to think, well, I'm a bit worried now because I've just had my blood pressure measured before this talk and it was 128/76. So I'm now in the pre-hypertension range and I'm feeling a little bit anxious, and that's probably pushing my blood pressure up slightly. And you can see as you go higher, you go from green into the orange, into the, I suppose, coral pink, and then into the sort of high sort of red. And that's because the higher your blood pressure is, the more risky it becomes. Now, there's been lots of controversy about this when these guidelines were introduced, about people saying we're medicalising normal hypertension. And that comes back to this question about, okay, well, what is normal blood pressure and how hard do we need to get it lower than it is at the moment? So let's start about, when did we know about blood pressure? So this introduces you to three physicians: Frederick Mohammed, Etienne Jules Marnier. I have to look at my notes here because they're very long names. Scipione Rizzo Rocca, I hope you like my pronunciation. And the one that, as medics, we know is Korsakoff, because when we measure the blood pressure, and we're learning as a medical students how to measure blood pressure, there are 5 Korsakoff sounds that we listen to when we're listening in a traditional way. Now, Frederick Mohammed made the first sphygmomanometer. Okay, I managed to say that. I'm quite pleased with that. It's quite a tongue twister. So that is the machine that we use to measure blood pressure. And so that was the first blood pressure cuff that blew up, compressed the artery and let it go and measured what happened. And then later on, Scipione and Korsakoff refined this to produce the first formal sphygmomanometer, of which there's a picture here. And you can see it's not far off what we've got today, it's just more electronic now. So this is a graph of what we're listening to when we measure blood pressure. So blood pressure is defined, what we do with these machines, and then we're telling you those numbers from this machine is your blood pressure. And there are 2 numbers in your blood pressure. There's the top, which is the systolic, and there's the bottom, which is the diastolic. Now, I was going to bring some balloons here today, but I thought that might cause chaos. But if you imagine your heart is a big muscular balloon and it's basically squeezing blood out to get it to all your organs. And it squeezes and then it relaxes, and it squeezes and it relaxes. And that gives you your blood pressure. But it's not just the heart. It's actually to do with the vascular resistance, the blood vessels it's going into. So if you were going to do balloons, and this is probably why I didn't do it because I thought this would probably go terribly wrong. If you have a balloon and a tube in between, the blood vessels themselves are also dynamic. They have muscular walls in the big blood vessels, and they also release back. So those changes in those dynamics are what gives you your blood pressure. So if your heart starts to do things that aren't quite right, that will change your blood pressure. And if your blood vessels start to become stiff and not as elastic, or they become very narrow, that will change your blood pressure too. And we can hear this all by measuring usually our brachial artery, the tension and the vibrations. That's what we hear when we're listening. And the same happens with an electronic blood pressure cuff, in that it's measuring the actual vibrations here. Now we'll talk about the machines for measuring in a moment. So you can see the heart's contracting and then it's relaxing, contracting and relaxing. So contraction is systole, relaxation diastole. Okay, we like our terms. And you can see here a picture of a blood vessel showing the importance of the other blood vessels in this picture. So you can imagine if your vascular bed, and it's a bit like a tree that sort of goes out, starts and spreads out. Normally it should be nice and low resistance as we get at the bottom. But instead, if they're getting stiffer and stiffer, the heart's having to push harder against it to get all that blood down to those organs. And those organs are really important. So if you start to tweak the blood supply, those organs start to complain. So how do we measure blood pressure? So one of the things I'm going to say to you today when you go home is to go and know your blood pressure. That's probably the big message. Go home, get your blood pressure measured, and get it measured a few times, and then get to know what is my blood pressure. and what does it do in different circumstances, because that is the key to being able to manage it. So there are lots of different options for blood pressure, and often when people come to see me in clinic, I ask them to bring their blood pressure recordings with them. And sometimes I have these beautiful graphs on paper. This is usually an engineer from Rolls-Royce that produces this beautiful graph, and then sometimes people bring their phone apps, and sometimes I've got a diary with things written in, and any of those is good. But we've got to be able to measure them. Now, most people will have an electronic meter, a little bit like the picture here, and like we've been measuring today. I've got one of these at home. The sphygmomanometer as Korsakoff, the old-fashioned manual one, we do still have those, and they can be very useful in certain circumstances, particularly if you need to get a very quick reading, or somebody's got very funny blood vessels, or they've got very fast heart rates. But actually most of the electronic ones are pretty accurate, and also they don't rely on us counting it, which sometimes we're not very accurate about doing when we're listening to the sounds. Now, these ones are the most accurate. There are lots and lots and lots of health things on the market, and I showed a picture of a few of those. So some of you may have very, very fancy watches at great expense, produced by various companies, that sit on your wrist and they tell you how good your sleep is, and when you had a nap, and what your blood pressure is, what your saturations are. These aren't good enough for blood pressure. And the same for wrist monitors. Again, they're not as accurate, and that's because they're further down that pathway. They're not next to the heart, which the ones that measure here are, and actually they're not very well validated. So I wouldn't rely on blood pressure in one of the watches because they're just not accurate enough. Now, in 5-10 years' time, they may well be. Technology is always changing, it's always getting better, and it would be great, wouldn't it, if you had a watch on here that, would measure all those things, provide an update. I was going to say to GP, but we can never get to our GP, can we? So it'd probably be to an AI who'd then tell us what to do, and perhaps it would all be solved. I don't know. We'll wait and see. So if you do have one of these watches, they might give you an indication or a nudge to go and do something about it, though. So I wouldn't discount them completely. But if you want to get some good readings and you're thinking about treatment, having one that takes the measurements on your arms is much better. So we sort of alluded to this already. Why is blood pressure so important? Okay, why does it matter that your blood pressure is high? If you didn't measure it, you might not even know. And that's part of the problem in countries where you can't access any measurement. You just don't know. And we could all be tootling around with busy lives, not knowing what our blood pressure is. And that's why sometimes hypertension is called a silent killer, because you don't know about it until things have gone wrong. And the reason we want you to make sure you know your blood pressure is that we want to start treatment before you get to what we'd call end organ damage. That sounds very sort of dramatic, doesn't it? But actually that's what happens. Those organs on the end of those blood vessels, the blood supply gets compromised over time. It gets narrowed, so the kidneys don't get enough blood supply. And that's why when we're assessing blood pressure, we dip the urine to see if there's protein suggesting they're leaky. We do blood tests, something called the UNEs, to look at the kidneys. It can affect the heart. The heart's having to work really hard so it gets enlarged, and if it gets enlarged over a whole time, it might be stressed so much you might have a heart attack, or it might just start failing because it runs out of puff. And then, of course, what I see is strokes, and those are types of strokes of both types, those where blood vessel pops and you have a bleed, and those that are ischemic where you get a blood vessel that's blocked. And hypertension is probably one of the major contributory risk factors to stroke. So if we were going to really work on one risk factor, then that would be the one we would really concentrate on. You can also see it in other organs. So if we look in the back of your eyes, we can sometimes see those blood vessels being narrowed and what they call pruning. So it is like gardening. We carry on with that gardening analogy of all those roots going down and being pruned by high blood pressure. So it's easy. We've done the numbers. We're going to get them down. Okay. Now this is why it's so difficult. The blood pressure we're measuring here is the result of lots of different systems working together to maintain that blood flow to all those really important organs, to the brain, to the heart, to the kidneys, to the eyes. And it's controlled by lots and lots of different, what we call homeostatic mechanisms. So if you look at the blood flow going through to the brain, it's very tightly regulated. And to do that, the body is producing hormones and getting into feedback loop systems. It's using sensors in your arteries in your neck and elsewhere. It's using sensors that are stretching in your heart. And it's also measuring how much blood volume you've got, but not only the blood volume, but how much salt is in your blood, how much water is in your blood. And these things are all working together. I'll show you a very complicated slide next. I don't expect you to take anything from that slide except that it's very complicated. I don't think there are any medical students here, but if they were, they'd know it all. Okay. So 3 main things that regulate blood pressure. Hormones, the brain, so the brain overrides because the brain is controlling everything, and particularly the brainstem and the hypothalamus, which produces hormones as well, and then the plumbing, the heart and the blood vessels. So all of those things are working together, and this is how they do it. So that's simple, isn't it? But why do we need all of that regulation? You know, if we're just here, your blood pressure should be the same, shouldn't it? So, unfortunately, or fortunately, your blood pressure varies hugely depending on what you're doing. So one of the reasons I say you need to go away and measure your blood pressure in different situations is that you need to have an idea of what your variability is. Now, when I was a medical student in my second year physiology class, we did a workshop on hypertension, and I was volunteered to get on the cycle, and I had to cycle as fast as I could for 20 minutes. There I was cycling, dripping with sweat, looking great. And then we measured the blood pressure every 5 minutes, and then we drew a graph. And the graph started and it went up, and my blood pressure was 180 systolic when I was at full pelt trying to get up there. And that was a normal response because I was working hard, my blood pressure was working hard, they needed to get blood to my muscles. And that's what happens when you get chased by a tiger. Now, did you know there's a special cognitive test where you have to look at animals, and I've just failed that one, haven't I? Oh my word. Right, lion. Oh dear, right. Or other animal, as you wish. So, but it might also it needs to keep your blood flow going when you're standing on your head. Now, I don't know how many of you stood on your head today. The nearest I can get to do it is a forward fold when you're doing yoga. And as I was looking through the talk today, just to get myself prepared again, I thought, what is my blood pressure when I do a forward fold? And so I did that for 5 minutes, and it goes up, interestingly, with your head down. I don't know whether that's consistent because it was a test of 1, and Harry will probably tell me that that's a terrible research technique. Now, if you're asleep at night, your blood pressure will be lower. If you've run up the stairs, your blood pressure will be higher. If you nearly get run over by a car, your blood pressure will be higher. If you're sitting watching a nice, relaxing television programme or a less fractious Coronation Street, it might be good and low. So it varies. So this is, I thought because I was going to ask you all to go home and measure your own blood pressure, I probably ought to do a bit of monitoring my own, because otherwise I wouldn't be following my own advice. So this was my blood pressure over a few days last week, and so I've just put it here. Really, what I'm just saying is it shows the variation in blood pressure. Now, I'm very lucky. My blood pressure is pretty okay, I think, but it does go. You might say, well, you've got a bit of pre-hypertension sometimes, but on average, mostly it's low and it's less than 120. But it depends what I'm doing. So you can see here on the highest I could make it go was 146.68, and I did, to make that go up, I did 20 squat jumps. I don't know whether you know, sort of go as, anybody fancy doing it later? As per Joe Wicks. So we started to do that in PE with Joe during lockdown. And if you do a PE with Joe, you'd expect your blood pressure to go high. Now, what I decided to do when I did this is I was going to do this live. Now, this is very naughty because I'm not following the advice that normally we give you. So the advice we give you when we're asking you to measure your blood pressure at home is to sit down quietly in a chair for 10 minutes, take your blood pressure reading, don't talk, don't drink a cup of tea. I don't know how you sit quietly for 10 minutes, but some people can do that. And then take the second reading, and that's the reading you are. Now, partly the advice for that is because when you come in to see us, you're sitting down, and a lot of the studies that tell us what to do with hypertension were done in what they call office readings. Now, office readings tend to be a bit higher than home blood pressure readings because of the stress of coming there. Usually they're done sitting. But I thought, well, actually, is that the best way to do blood pressure? Because actually, most of us are not sitting down gently for 10 minutes. So I thought, why don't I just ignore that advice and just do it? So this was a little experiment. Again, poor research protocol, but, it's like history of the old physician experiment on myself. So as you can see, there's variation in blood pressure. There's not actually as much variation in blood pressure as I thought there might be, but everybody's different. And it does go up when I'm a little bit more stressed. You can see the first one is preparing for this talk, because I thought I only had a day to do, but as Val will tell you, I got the date wrong and nearly turned up last week. So that all settled down a bit after that. Interestingly, multitasking was causing low blood pressure. So actually, it may not matter that much whether you sit down for a long time, because that's not a natural sort of way of measuring blood pressure. That's not naturally what blood pressure does. And actually, a lot of when we're making decisions about blood pressure, we sometimes ask you to go and have a 24-hour blood pressure monitor. Now, has anybody had a 24-hour blood pressure monitor here? Who would describe it as fun? No, not fun. So it blows up and down sort of every 15 minutes in the day and a bit less at night. And you might say, well, it's a bit like Higgs boson, isn't it? That you actually change your reading by actually trying to measure it. So it's a bit stress-inducing, isn't it, 24-hour blood pressure monitoring? But actually it gives us a lot of information. It gives us that variance over the day. But also, we don't get you to sit down for the whole of that 24 hours. And we know that's a much better indication of what your blood pressure is. So I suppose what I'm saying is, do your blood pressure. Don't worry too much about the sitting down and having everything quiet and not having a chat. There are little studies that have shown you that chatting and those things make your blood pressure go up. But we're all alive and we do these things. So I think not doing that is a bit artificial. So this is what blood pressure should do throughout the day. So it should vary. And what it should do is it should go down when you're asleep at night, and that is called blood pressure dipping. Okay, now we know that if you lose your dipping, that is an indicator that your vasculature and your vascular response is a bit impaired. So if we see somebody that's got slightly high blood pressure and they're not dipping at night, that would perhaps push us a bit further to treat. Now we only get this sort of graph if we do a 24-hour blood pressure monitor. So, we're coming back to this again. It's not quite as easy as we thought, is it? It's not just about one number. So you can get different sorts of blood pressure patterns and different hypertension depending on you and depending on whether you're a dipper or a non-dipper, whether your hypertension is due to underlying heart disease or it's just very stiff blood vessels. Or whether it's other factors affecting your blood vessels. Perhaps your blood vessels aren't quite as elastic as the person you're sitting next to you. It may be I have really elastic blood vessels. So some people get very significant morning hypertension, and there's lots of studies that show that Monday morning is a peak time for having myocardial infarctions and strokes because you get a surge of blood pressure, and Monday morning is a particularly stressful time. People are going back to work. And then there are other people who have blood pressure that is worse towards the middle of the day, to the end of the day, and some people just are very hypertensive at night. So that means that some people might benefit from blood pressure medication at a particular time of day. Some people might benefit from a blood pressure medication that lasts through the whole day. Some might benefit from one shorter. And we're not quite finessed about doing that. So if you know what your blood pressure is and what it's doing and how you feel, you can then sort of change what you're doing. That's my phone. So, can I just answer it? That's really rude, isn't it, really? It's my work phone. It's on. You see, that's a modern phenomenon, isn't it? You can't leave your mobile phone. Stress, it's like Pavlov's dog. We're all entrained to our mobile phone now. So I'm going to talk about some other situations that cause a few challenges with our blood pressure. And I suppose what I'm coming down to is that when you're talking through with your GP, or you're talking to me, if you've had a stroke or anybody else about your blood pressure, if you're aware of what your blood pressure is and what affects you, that can allow a more tailored plan of what is the right hypertension treatment for you. And I suspect in another 5 years, we will know a little bit more about your genetic makeup and how you respond to different medications, which have more effect on one person than another. And that will allow us to have a really tailored plan for blood pressure. And we'll be screening you all when you get to 30, and you'll be on, we'll say, actually, you're not going to need blood pressure medication until you're 44, you'll have it at 53. You're going to live till 100 and never need it, and we'll all hate you. You know what I mean. But there are particular areas where we have to be aware. So you might be identified with high blood pressure. You might be on some medication, but that's not the end of the story. Things change throughout life. Not only do we all get older every day, but other things happen. So if you get unwell, then your blood pressure might suddenly drop. And in that point, you don't want your blood pressure medications then. So some of you may have heard of what we call sick day rules. So if you're on high blood pressure tablets, particularly ACE inhibitors, so that's ramipril or perindopril, or diuretics, or ARBs, which are things like losartan or valsartan, then if you're sick with diarrhea and vomiting or anything like that, you're asked to hold those. Okay, so we know that if you become unwell, your kidneys can be affected, and then we give the medications on top. Actually, we can damage the kidney. So very important to be aware of sick day rules. So that can be caused by lots of different things, a heart attack, sepsis. And usually if that's the case, then hopefully you've been seen by a medic, and you might have to come into hospital if that's the case. But sometimes you've got norovirus, and the last thing you want to be is in ED vomiting on a 12-hour trolley wait. So it's useful to know, keep hydrated, stop those tablets temporarily. Now, one big problem that we face with a lot of our patients is postural hypotension. So postural hypotension means that when you're lying down or sitting comfortably, your blood pressure might be high, but when you stand up, and it might drop a huge amount. Some people drop by 40 millimetres, 60 millimetres of mercury. So I haven't mentioned this, so I apologise, but when we measure the blood pressure, it's done in millimetres of mercury because of the mercury thing that went off up and down on the traditional thermometers. So it's not unusual for us all to have a postural drop. So normally when we go from lying to sitting or sitting to standing, our blood pressure drops a little bit, our blood vessels squeeze, and our heart goes a little bit faster to get that blood pressure up. And that's one of our homeostatic mechanisms. Now, sometimes if you've got very bad diabetes, or as you get older, those mechanisms become sluggish, and some get really sluggish. So, you're really hypertensive lying down, and then you stand up and you go, well, actually, you're not hypertensive anymore. And that's really important, because if you have big blood pressure drops, you'll faint. So actually in that situation, it's important what your standing blood pressure is, because we could keep you in bed for the rest of your life and have perfect blood pressure, but what sort of life would that be? Now that does mean you might still have surges of blood pressure, and very variable blood pressure is very difficult to control. So we'll talk a little bit about getting older, and we'll talk a little bit about these last two. So the first thing is, once you're on high blood pressure tablets, once you're on antihypertensives, is that it for life? Yes, probably. Okay, there are very few situations where people manage to reverse their hypertension. The situations where that can happen is if you've got a secondary cause. So, for instance, there are tumours you can get on the adrenal gland that produce too much hormones that cause hypertension. If that's removed, then the hypertension goes away. If you're very overweight, and you change your diet and lose a lot of weight and do a lot of exercise, that may reverse. But that requires quite big changes. But really, once you get above 40 and you've got blood pressures that are above 140 over 80 consistently, you're going to need medication, and it would tend to be for life. Now, we were talking earlier, nobody wants medication. So what can we do about that? I suppose the sad thing is that it's probably too late for all of us, okay, because we've all developed our slightly stiff blood vessels by this point. So one of the things I want you to do when you go forth is to really work with your grandchildren and your children and your great-grandchildren and your nephews, and really work on trying to get the message about healthy diet and doing exercise and, trying not to eat too much. And these are all modern, I suppose, evils in our world that are part of treats that we see, and it's very, very complicated to sort that out. Labile and variable blood pressure, white coat hypertension. So white coat hypertension is the blood pressure you get that surges up when you're in a very, very stressed situation. So the classic thing is coming to see me in clinic. Measure it's really high, then it comes down, particularly if you've not been able to park. Parking is a very, very clear source of hypertension, and I might suggest banning car parking. I'm not sure whether that would work. Often that person will go away and they'll measure their blood pressure at home and it will be normal. And so they'll do some measuring, send it off to the GP, and they'll say, well, okay, it's normal. So the answer to that is don't go and see any doctors or get in any stressful situations. Now, that's really hard, isn't it? And it's also recognised that people who have white coat hypertension are at higher risk of cardiovascular and stroke events. And it's, for some people, the sudden changes in blood pressure can be very risky. And the question is, how do you treat that? So my recommendation in that scenario is you need quite a few readings to see what your baseline blood pressure is. And if your baseline blood pressure is above 130 over 80, then you probably ought to have some treatment to reduce that variation. And there are some blood pressure medications that are better at reducing variation than others. So calcium channel blockers seem to reduce that variation more than the other sorts. There are other non-pharmacological things that you can do, and we'll talk a little bit about that in a moment. But it can be really, really challenging. And this is why, if you know your blood pressure, you can sometimes look at the interventions that might help prevent those surges. So in my area of practice in stroke, blood pressure acutely is very, very important. So in this section, you can see in this graph primary hypertension. So really what we're talking a lot about today is how to treat blood pressure before you get to the stage where you're showing damage to the brain or the heart or the kidneys. We know when people come in with strokes, as part of that reflex, their blood pressure goes very, very high. And if you've had the type of stroke where you get a blockage of a blood vessel, that high blood pressure is actually maintaining perfusion. So if you think back to the plumbing analogy again, you've got a blood vessel that's blocked and you're trying to get blood back to the rest of the brain, you've lost part of your circuit, so you need to push more through the rest of the circuit. So the blood pressure goes very, very high. And we know with ischemic stroke, if we lower it too much, then we actually make things worse. Now, we have two different situations from that. So if we're giving thrombolysis, that's the clot-busting medication to try and get rid of that clot, we know that we need to lower the blood pressure a bit because otherwise the risk of bleeding goes up. So we actually lower to less than 180 in that situation. Not much lower than that, but we don't let it sit at 200 or anything like that. For intracranial hemorrhages, so that's where a blood vessel ruptures and then the blood leaks out, it's different. We know getting blood pressure down really quickly, down to less than 140 over 90 is really important, and we need to do that within 6 hours. So the approach is very different for two different situations. And we didn't used to know this sort of 10 years ago, so our practice has changed as we've learned more about blood pressure and its impact. And if you draw a graph of when you had an ischemic stroke, often it's high in the first week and then it comes down. We'll talk a little bit about that temporal relation throughout the stroke journey as we go along. Age and blood pressure. So it used to be, it was 120 plus your age was your normal blood pressure. Does anybody remember being told that? Yep, so I'm sorry, 170 systolic, that should be normal for me. So, of course, that was a sort of, well, who knows where it came from, because the evidence wasn't very clear, but I think it came from some observational studies that noted that as you got older, your blood pressure got older, and that was just part of normal ageing. And I think we've changed in saying that actually healthy ageing doesn't necessarily mean high blood pressure. And so you can see that as you get older, the risk of stroke increases, and it increases more if you've got high blood pressure. So high blood pressure does go up, but it's not necessarily, although it increases your risk a lot, not everybody with age increasing gets increased blood pressure. And actually, interestingly, the most important factor in this is where you live and what your diet is like. And if you look at people who forage, and there's not many people who forage as communities, but a recent study looking at communities who just forage and farm and a very lean body mass, if you look at their age change of blood pressure, it's very small. If you look in America, where of course very westernized diet, very high salt diet, they say, well, actually for every decade you live, your blood pressure goes up by 7 millimeters of mercury. So it can be changed, but it's hard. So as part of looking for information for this talk, I did a bit of looking around at what other people are doing and what was more recent. And there was a very recent Japanese hypertension conference, and it came out with some really, really, really good stuff. So I've got a pile of reading material from that, which obviously I won't give you to do. But in 2018, so this was, the effect of this was talked about in this meeting, they came up with this sort of view on hypertension. Now, you may know that in Japan there is a lot of centenarians. Okay, so it's one of the oldest lived healthy communities. And they came up with this slogan, good blood pressure for lively 100 years. And I put this on because I really liked that. Good blood pressure, not for living 30 years disabled, but living 100 years good and fit and, you know, doing things that you enjoy. So I liked this idea. And this was their strategy. And you can see that it's quite complicated, but it involves all sorts of areas. And I don't expect you to read all of this, but actually if we're going to get control of hypertension within our whole community, it's not just about you going home and knowing your blood pressure and changing things, but it's about the whole of society making it easy for us to change our blood pressure. So it's not easy at the moment when you go into the supermarket and, you know, cheese is 2 for 1, or, you know, the bacon rashers are on special offer, and the sweets by the counter for the kids to eat, and it's, you know, I've got 2 little ones, it's like, oh, mummy, I just want a candy, and like you're trying to say no, but it's hard to say no. So it involves all sorts of people. So education and awareness, which is what you're all doing today. It's making sure our health systems are monitoring and encouraging people. But it's also about getting people to be aware, getting people to exercise, getting people to be a healthy weight and get a healthy diet. And that needs to be lifelong. And you can see they've sort of noted particular sort of groups of people that might have particular areas, so adolescents. So you'll have seen reports today in the newspaper about the amount of exercise children are doing and how they're struggling to do that, particularly teenage girls find it very difficult to access or to be encouraged to do sport. And that's a real worry. But there are also lots of older mothers. So I was a geriatric mother. You know, at 40 I had my first one, which is quite geriatric, isn't it, really? So when I came back and had another one, I was really geriatric. But anyway, but you get more hypertension and more comorbidity if you have older mothers. And then what do you do when you reach your latter years, when you're 96 and your body weight is a little bit less? Well, actually, again, it's about change. So quite often, if you lose body weight, your blood pressure goes down. So some people no longer need blood pressure medication as they get older. So the the lady you saw doing a forward fold in brilliant fashion in the first picture is my mother-in-law. And she did that when she was about 88. She was incredibly flexible. And she had quite bad hypertension. But in her last 2 years of her life, she had loads of hypertension and syncope, which is fainting. And she had to be taken off all her antihypertensives. So again, it's about knowing your blood pressure and knowing that things might change. Blood pressure is not static. So what we're going to do about this blood pressure, we've identified it. You're sort of resigning yourself that you might have to have tablets. But there are other things that we can do, and we've just started to talk that through. So lifestyle, really, really important. And we're going to talk a little bit about salt particularly, and diabetes and exercise. So, but salt is really what I'm going to concentrate on. All the other things, we all know about not smoking, reducing your alcohol. Alcohol also increases hypertension. It seems to make it worse, particularly in males rather than females. And recreational drugs. Now you might say, well, that's not part of my lifestyle, but for many young people, cocaine use, particularly in the last decade, has gone up hugely and causes hypertensive crisis, and certainly something we see within the stroke unit. So it's being aware of all of those things. And then we mentioned secondary causes, which I'm not really touching on today, but you can sometimes find underlying problems with hormone regulation and with the kidneys and the adrenals that you can do something about to change your blood pressure, but they're very rare. Again, looking back at our whole community, the environment we live in is really important. So if you live in a highly polluted area, your vascular risk is higher. So if you live in a very urban area with very high traffic, with high particulate matter, then you're more likely to have hypertension. It's also very difficult to exercise if you open the front door and there's dual carriageway in front of you, if there are no parks, if there are no cycleways. So actually our urban structure and development is really important. Is there anybody in the audience who cycles? Excellent, well done. How many times have you nearly been knocked off? 10 times. So I cycle to work, or at least I try to, and I would probably say I've had 4 near misses in 12 years. So I think I've been pretty lucky. But you do take your life in your hands sometimes, cycling, but it's a great way of getting around and very environmentally friendly. But we don't do cycle lanes very well in this country. And we don't protect pedestrians. The car is king, and it's something we've got to change. And again, those are the things that we need to do for our children, because that's who's going to make the impact, not necessarily us. And then, of course, there are drugs. And I put surgery in brackets because very rarely you can have surgery called sympathectomy, where you take the nerves away from the kidneys. It's very rarely done. And I'm just mentioning it as an aside, really. So these are examples of the type of blood pressure medications there are. They are not an exhaustive list, and it just gives you a little bit of an idea of where they act. And most of the medications that we have act on the blood vessels and open them up, they dilate them. So calcium channel blockers particularly do that. And calcium plays a very important role in muscle activity. So they dilate blood vessels. I've actually spelled amlodipine wrong there. I don't know whether anybody noticed. So then there are things that make you wee out more, so reduce the amount of intravascular fluid. That's diuretics. You'll all, if any of you are on those, you'll know that you sometimes leave those till later if you're having a day out. There are alpha blockers which work on the heart and the vascular system. And then there are probably the most common ones that we use that act on the kidneys. Now, in this picture, you can see how important the kidney is for blood pressure. And the blood pressure is regulated by sensors in the blood flow going into the kidney and then the blood flow coming out of the kidney. And that's moderated by the renin-angiotensin system, which is also impacted by the aldosterone that's produced from the adrenals, which sit above the kidneys. So, as we said before, it's quite complicated balance of systems, but we have found we can block particular areas. So that's where the ACE inhibitors, things like ramipril And then a bit further along that line, the ARBs, which are things like losartan and valsartan. And there's lots of them. They end in rils or tans, if you like. And then we've got some that act on the brain. The methyl dopa is only really the one that acts on the brain, and we don't use that very often except in pregnancy. So they all try and do these little bits. Now, you can imagine if you stop one bit, you might shift things a little bit the other way, and they might cause imbalance in those systems. So sometimes the problem we get is because the body compensates in the wrong way. So kidney function and monitoring that when you're on these tablets is quite important, because actually these tablets can sometimes damage the kidneys. And that's why, again, we come back to the sick day rules to protect your kidneys if things change. Okay, so you see your doctor. They might say, okay, we'll start this blood pressure medication. We might titrate it up until we've got to a blood pressure that on average is less than 130/80. That's what we like post-stroke. They might be happy with 140/80 and less if you've not had a stroke. If you look at your pre-hypertension, there may be some debate with your GP about it, so it's one for discussion. So you start your medication and you see what happens, and it can take a little while for the blood pressure medication to work in. So, it can take 2 or 3 weeks for it to really work into the level where it sort of stabilises out. And that's only then you might add another medication. And then you need to wait. You have to be patient. So if you've got blood pressure with no evidence of end organ damage, it can take some time to get your blood pressure into something that's more controlled and fits in with everything else. It's not a quick process. And it shouldn't be a quick process because you don't want to suddenly go the other way and then come off everything and end up yo-yoing. In the particular areas we've talked about, like after stroke, there we're doing things very quickly. And that's because we've got evidence that doing it quickly helps. But if we do things too quickly when we're starting medication, you run into more side effects. It's much better to do it slowly and gradually. Now, that may depend a little bit on how high your blood pressure is. So if your blood pressure was 200/100 and it was sitting there, then we'd want to be a bit quicker because obviously that's a more dangerous blood pressure. So you've given all these tablets and you say, well, when am I going to take these tablets? And we've sort of mentioned this a little bit, depending on where your blood pressure is it all the time? There was this one study that came out 2020, and there was about 14,000 patients in it, and they looked at patients taking their blood pressure medication in the morning or at night, and it seemed to be better if you took all your medication at night. It was a really big study. Now, these people in this study were on 2 tablets, and it didn't say which tablets they were on in the study. If you're on a diuretic, like indapamide or furosemide or bendraflumethiside, you probably don't want to take those before you go to bed, otherwise you'll be up weeing. So you have to be practical with these sorts of things. And it's also about remembering. So often if people are going to bed at different times, it might not suit them. If you're a night worker, it might not suit you. The most important thing is to remember to take them. That's the first thing, regularly at the same time every day. And then deciding what's the best time for you. If you can remember to take them all at night, then great. We are institutionalised and we prescribe everything for the morning. Okay, but that doesn't necessarily need to have it. So do talk to your doctor and say, can I take this at night? And you say, there's this really big study that says it's better, and we'll say yes. In hospital, we struggle to do this because routine drug rounds in the morning. And when people go home, if they've got carers doing the tablets, they don't like to come in last minute at night. So you have to be pragmatic about these things. But if you can take your blood pressure medication at night, it does seem to have better benefit. Now, we could do a whole talk about genetics and how it affects what we do and how we do it. There are probably about 273 loci, those are little bits in the genome that are related to blood pressure. And they're different for different people. So we already know that if you are of African Caribbean descent, that calcium channel blockers are first line and much better than ACE inhibitors, and that salt restriction is much more important for your blood pressure. So we know it on that sort of gross genetic level, but actually there are lots of other features. We just don't know enough about this yet. But again, 5-10 years' time, we'll be able to finesse what we're doing because we're going to know a lot more. So salt. Who likes salt on their chips? I love a packet of ready salted crisps. I'm terrible, I confess. It's very hard. So salt is very important because it's part of all those regulatory systems, and I'll show you another little picture about that later. And salt intake changes those regulatory pathways over a period of time, and that results in gradual high blood pressure. Now, there are lots and lots of studies that say if you can reduce your intake of salt, you will drop your blood pressure. You might say this is not very much, by 2 or 3, 4 millimetres of mercury. Now, when I was talking about the antihypertensive medications, I didn't actually tell you how much each one made your blood pressure drop, which might be a question somebody was going to ask me in a bit. Most of those medications drop you by about 4 to 6 millimetres of mercury. So perhaps not as much as you think. But any drop is good. So that's another message. Even if you can't get to those perfect parameters, any drop is good. But this is something that doesn't have side effects and could make a huge difference. But we're brought up on salt. We're all addicted to it, really, aren't we? And, trying to stop, people eating crisps, they're all available. We're so lucky, really, that we have so much available to us. And it's a real challenge. So if anybody's got any really good ideas, then let me know. And there are lots of campaigns. There was one about slugs a few years ago, wasn't there? It's a bit unfair on the slugs, really, but there hasn't been many recent campaigns. And interestingly, what countries recommend is very different. So this is a map of looking at different countries' approach to salt intake. So the dark ones, orangey, is there's a national policy commitment to reduce salt. So that's probably where, there's, is the most regulated area. And then you get all the way down to sort of the green ones where there's multiple mandatory things, and then in the middle people are a bit voluntary and see how you feel about it, and we're sort of in the middle. And actually, if you look at the NHS website, it says we should be having 6 grams of salt or less a day. The WHO, which obviously gives advice to every nation, says less than 5 grams of salt a day, and on the Canadian website it says less than 4 grams of salt a day. So I usually say to people come and see me, if it's good enough for Canada, it's good enough for us. So And you wonder why this is so different. And it's all to do with money and where the money goes and how you get money in your coffers and the power of the food industry, which is huge, governments don't want to force industries to do things because they might lose profits, and then that might impact on what happens to them. And governments are often transient. We've got an election coming up soon, haven't we? And they haven't got long-term plans, and this is always the problem. You need a long-term plan for something like this. So salt's important, but it's actually part of a pathway that fits with lots of other things. So some of you may have come across low salt, which is actually salt made up of potassium, and potassium works in the similar pathways with salt, so can sometimes help to lower your blood pressure. You have to be really careful with extra potassium though, because if you're on medications such as ACE inhibitors, those can push your potassium up. So this isn't really an approach I would recommend. You probably ought to avoid licorice, because that's got an aldosterone-like approach, and that can raise your blood pressure. So I hope there's nobody who likes to chew licorice at night, because it's disgusting, but that's a different. But actually, also there's a relationship with calcium and vitamin D as well. So if your vitamin D is low, that can push your blood pressure up, not by very much. But in winter and summer, your blood pressure is different. It's lower in the summer and higher in winter. So I'd like to recommend we all move to Australia. I don't know if it's any better, but so again, complicated stuff, sodium. Okay, so this is perhaps a little take-home message. The top 10 foods for salt intake. So how can you cut those out of your diet? So a lot of bread, particularly, I think, I love healthy bread, and I like the really brown, crusty rye bread with loads of seeds. Often those breads have got more salt in, so sadly I love bread, but pizza's terribly high salt. I think they're a bit unfair on sandwiches, to be honest. depends what you put in your sandwich. If it's ham and cheese, yes, I'm sure it's high salt. But certainly cold cuts and cured meats are very high salt. A lot of things are prepared food. So often the key to reducing salt in your diet is to make your own food. And that's easier for some people than others. And actually fresh vegetables and fresh fruit, if you're going to a standard supermarket, are really, really expensive compared to a ready meal. And we're quite lucky in Nicolover and little areas. We do have little pop-up markets, vegetable markets. And if you don't know, if you can look on one of the websites, you can find the little vegetable markets. They're a really good place, and they're much, much cheaper than supermarkets. Eggs are a good food, actually, but again, not too many of them. But it is all those nice things that we like. I mean, I'm a bit of a cheesetarian. I love cheese. So think about this one. So exercise. Regardless of the characteristics of the participants in exercise, there was a reduction in blood pressure in the hours following an exercise session. There you go. Exercise is good. What exercise? Probably doesn't matter. The recommendations are 150 minutes over the whole week, or at least 3 times. Anyway, look, try and do as much exercise as you can. A brisk walk of 40 minutes every day would be what I would advise. Anybody can do it. You don't need a gym pass. If you like biking, that's also a great one. If you like swimming, but walking is where to go. If you can't walk or you've got bad joints, you can get little arm cycles to do your arms and your legs sitting. You can do yoga and chair exercise classes. There's loads of stuff on YouTube to do that. But the important thing is probably to do a little bit every day. And there's a nice website here. It's quite good. Resistance exercise, probably, really resistance exercise is probably not good, but small weights are good. So a bit of resistance exercise is good. Right, meditation. This is a quote from the Harvard Medical School website. It follows with a little package you can go into that costs $19.99 a month, so I'm not sure how good it is, but Dr. Benson, I've no idea who he was. I don't know whether he was in ER. Anyway. And I thought, okay, well, is there anything behind this? Well, actually, there is. And I do quite a bit of yoga, and people say yoga's very good for everything. And it probably is. And I thought, well, does it help to do yoga? Apparently, it's the breathing that helps, not necessarily the yoga. So this study looked at 3 groups. One group did nothing, the other group did yoga with the breathing, and one group just did the breathing. And actually, it was the breathing that made the most difference to the blood pressure. So if you take anything away from this talk, it is to breathe. So we are all breathing, as you know. So what type of meditation and what type of breathing you're doing and what's the best? There's loads of different recommendations, and I cannot tell you which is more effective, whether it is really that effective. There is certainly some physiological background to meditation in changing your the level of your cortisol and your fight and flight hormones, and changing your pulse rate and your blood pressure. When we were medical students, we learned about what we call sinus arrhythmia, which disappears as you get older, but when you take a deep breath in and out, your blood pressure slows and then speeds up. And that's due to the change in the intrathoracic pressure. So that's what we're doing with meditation, is we're sort of slowing everything down, and that seems to open up the vascular bed. So it probably doesn't matter where you do your meditation, whether you do it lying down or sitting down. It's all about the breathing. And there are 3 techniques that we're recommending and seem to have some form of benefit. So the first one is box breathing. I don't expect you to read all this. My children do this at school. I don't know whether you do. You just have to be able to draw a box, and you take a deep breath in for one side, counting to 4, then you hold it for 4, and then you breathe out for 4, and you just keep going around the box as long as you can doing it. Or you can think about the box. There's another one where you, similar to the box, where you breathe up and down on your fingers. I use that with my very manic 8-year-old to calm down. Sometimes it works. And then there's a 4-7-8 technique, which is deep breathing in for 4, holding for 7, out for 8. So some of you might be aware of that. And then there's alternate nostril breathing. So before you attempt that, I'm just going to blow my nose. Excuse me. So you must always have a tissue. Has anybody done an alternate nostril breathing? Okay, so thumb and finger. So you close one nostril, you take a deep breath in for 4, 5. Close your nose, and then let the other one out. And then you go back up. Close your nose. I really did it for the nasal sound effect, but and then you have to blow your nose again. So it's a little bit messy, but actually it's a really interesting way because it does make you slow down your breathing, and you have to think about it. So I think if you're going to try one, that's probably the one to go for, and you probably need to do it for about 10 minutes. If you've never done it and want guidance, there is a lady called Adrienne who does yoga with Adrienne, and she does nasal. She's got a whole section on nasal breathing, but lots of people do it on YouTube. So if you want to learn how to do that. So I'm just going to mention a couple of other features. So I did touch a little bit on pollution. So certainly air pollution is a big factor in lots of countries. OSA stands for obstructive sleep apnea. So obstructive sleep apnea is a condition where people stop breathing and their oxygen levels go low at night, and then they suddenly awake. So they get very, very poor sleep, and it's associated with hypertension and diabetes. More likely to happen if you're a little bit bigger, but not always. If identified and treated, that can reduce the risk, and it can also reduce hypertension as well. And that's often part of what we call a metabolic syndrome. So metabolic syndrome is really a combination of obesity, diabetes, hypertension, which is suggesting that all those hormonal things that make that blood pressure pathway become a little bit deranged. They're not working properly, and that results in a cardiovascular risk that increases for everybody. And then we've talked about genetics. I mentioned morphology, which is really about body shape. So we're all different body shapes, and that can affect your blood pressure as well. So if you're very short and very tall, your blood pressure may change. But also, we were having a discussion about, when we were measuring blood pressure, about cuff size. So I should have mentioned this earlier, but when you're measuring your blood pressure, you need to make sure your cuff can fit snugly around your arm and has got enough room to go sort of 1.5 times around your arm, otherwise it won't fit properly. Most blood pressure meters come with one standard cuff. So if you're very muscly or you've got quite a big upper arm, you might need a bigger size cuff. So just look out for that. Right, blood pressure after stroke. So we talked about the very acute phase, and these numbers are the days after stroke. So when I see somebody acutely, I have one approach, but then I have to modify my approach as somebody is rehabilitating. So sometimes patients will need to stay in for 2 or 3 months as they're recovering from their stroke. And we may have to change what we're doing with their blood pressure as we go along. So again, this is coming back to that message that blood pressure isn't always static. So actually blood pressure comes down at 7 days. We might get to 3 days and somebody has been lying in bed for 2 or 3 weeks and is just starting to sit out. And so all those reflexes that say, oh, I'm now standing up, are a bit out of practice, and the blood pressure can suddenly drop and we have to back off blood pressure medications. And then as people recover and they get to standing and then to stepping, that blood pressure can gradually start to creep up again. And often it keeps creeping up as they get better and better. And then you have to reintroduce the blood pressure medication. So that's why it's important, again, to be aware of what your blood pressure is. So this, again, is from the Japanese. This is about how digital hypertension, it's not a diagnosis, but it's almost saying that as time goes by and we have all this tech that's able to measure, that will help us control our blood pressure. And there are lots of different things here. And it's not just about being aware of your own blood pressure, but being able to modify what you do, having advice about what to do that. But also all these devices collecting lots of data from people to provide big databases of blood pressure and look at new treatments. So technology will help us from that point of view. Obviously, there's going to be issues about, is the AI got your best interests at heart? Hopefully, yes. But it maybe if they sell something to you on the side, like a better blood pressure meter that costs more, perhaps it isn't. I don't know. We'll have to wait and see. So this is my advice to take home. So first of all, know your blood pressure. I think once you could say, I can pick a random number out of the sky, but probably once you're 40, you should know your blood pressure. And you should be happy to take your blood pressure and happy to know what those numbers mean and to be able to go and get help if you don't. And I would advise you, if you're measuring your blood pressure, get an app, because an app allows you to put the numbers in. Usually it puts it in the zone, you can see where it is. Often it's linked with heart points, so exercise, diet. So, if your blood pressure's a bit high and you reduce your salt and do some more exercise, you might see it come down, and that's quite a positive thing. And then you might just do it every now and again. You can send those results to your GP or your consultant that's looking after you if you've got one. And they can see that and go, yeah, they're doing okay. And it means you go along to your pre-op clinic and you go, look, there's my home blood pressure monitoring. Cut down on salt. So go home, have a project, work out how much salt you're eating a day. Now, most foods put salt as what the ingredient is. Some put sodium, and if it's sodium, you've got to times it by 2.5. You remember to say that. Make sure you get your children involved and your grandchildren. This is so important. Last week, and I'm not sure whether I'm in trouble for it yet, I stole the salt from the stroke rehab unit hostess trolley. I've got to go back next week and see if it's been put back. See, rebellion. Eat and drink well. We can all eat more vegetables, more water, less alcohol. Okay, none of those fizzy drinks that we get pushed to drink. And be proactive. And so I've said walk, cycle, swim, breathe mindfully. And then I suppose campaign for a healthy environment, campaign for better healthcare. So this is on the little handout. So in summary, if we take charge of our blood pressure, we can be healthier and we might save some lives. But as I say, nobody said it would be easy. It's not straightforward. And then my final thing, and I may get trouble for saying this, but it's also to say thank you for you all coming here, because it's really nice to see so many people here interested and asking really insightful, important questions, and hopefully some more will come. But I also wanted to apologise to all patients who are having to come into the hospital system at the moment who may have experienced a stroke, because NHS systems are under massive strain. We are not able to provide the same stroke service as we could 5 years ago. And this is very distressing to the very, very dedicated team of people I work with. The ambulance waits are huge. We can't get people to the stroke unit in time. And for many people who've had strokes in the last 5 years, we've not been able to get people to follow-up clinics. So if you know anybody who has been through the service and we've not seen them, please pass on our apologies. We're just struggling to catch up with anything. And I would say, I mentioned a little bit about election. I'm not political in any way, but I think the NHS has been forgotten in the current political situation. We're facing an austerity. We're facing frozen jobs, jobs being lost, when I've never seen the NHS under so much stress. And we need some investment and a clear plan, and I think it's being forgotten amongst everything else. So go forth and campaign. Right, on that slightly feisty note, I'll step down and take questions.
Thank you. Earlier on in your slides, there was a slide that said something like morning hypertension, increased physical activity in the box underneath. Could you explain that, please?
Oh, gosh, let's go back and see. So we'll go back. That one, that's the one, isn't it? So morning hypertension here, and you were talking about the high physical activity, this bit here. Yeah. So if people are doing a lot of activity, so people are runners and people who are weight builders and those sorts of things, they do sometimes more likely to get a higher hypertension in the morning. Now, that doesn't necessarily mean that it needs treatment. It all depends on whether it's sustained or not. Now, there is when you exercise a lot, you get left ventricular hypertrophy, which you also get in hypertension. So we sometimes see in athletes signs of hypertension on an ECG, and they have very slow heart rates, as you might expect, that you might see with somebody who has got hypertension-related disease, but they haven't. So it can, I'm not an expert on athletes in hypertension, and it can be very tricky to know what to do with those people. In fact, I will go and look that up a bit more, because that's a really important question. I will write it in my head for later. And then there's a gentleman third from the back, just there.
Thank you, Doctor. Early in your talk, you advised us to all go home and take our own blood pressures, that we were to sit down quietly for 10 minutes before doing so. Fair enough. Are you advising us to do it 365 days a year, or possibly just 7 consecutive days once a month? And secondly, does the intake of a heavy meal have any effect on our blood pressure?
So, yes, it can do. If you've had a really good meal, it's the sort of classic thing is that you go out for Sunday lunch, you eat big dinner, you have a glass of wine, and all your blood vessels vasodilate, because it's a bit warm in there as well, and all your blood goes to your tummy because it's going to digest that, so it lowers your blood pressure. So you sometimes get this phenomenon of postprandial fainting. And if you're on blood pressure medication, that is more common. So going back to my mother-in-law, while she was on hypertensive tablets, she would quite commonly faint if we went out and had a very, very hot meal. So be careful of hot meals and very hot scenarios when you're on blood pressure tablets. And the other question, which is how often? How often? I think every day for 365 days is a bit over the top. So I would suggest, while you're getting to know your blood pressure, I would probably do it day and night, because that gives you variability. I'll probably do it for a week, and if it's all normal, then check it once a month. If it's higher than that, you probably want to get 2 weeks of readings and then take it to your GP. And then if you're starting medication, you probably want to do it probably 3 days a week until you're having it monitored again. It's all about applying a little bit of, I suppose, common sense to it. But what I don't want you to do is to go home and measure it, every 2 hours. And it is a balance. So, I've had a lot of people come back to me and said, well, my GP told me not to bother monitoring it anymore. I have a lot of discussions with my husband about this, because he gets very cross with healthcare professionals who take a paternalistic approach to telling people what to do. And he would said, he's not a medic at all. He says, I'll do what I think sensible. And most people are very sensible. So the gentleman just third from the back.
If you have high blood pressure but a low heart rate, is that less dangerous than someone who has high blood pressure but a higher heart rate, so it's basically the pulsing is happening more frequently? So
certainly having a low pulse rate seems to give you a better cardiovascular sort of outcome. So actually, if you've had heart problems, we often put people on beta blockers. So if we were trying to lower your blood pressure, we wouldn't want to put you on a beta blocker if you've got a very slow heart rate, because it might make it too slow. So it might affect the choice of medication. Now, there are exceptions. So some people, if they go from having quite a normal heart rate, say 60, and then go to something like 40 with a high blood pressure, then that would need looking into, because very occasionally people go very slow because the electricity in the heart's not working properly. And that gives you a very big pulse pressure as a compensation, and lowering that blood pressure might be dangerous. So if you had a sudden change of pulse, say from 70 to 30 or 40, you must go and seek advice. If you're naturally running at 52, and you look at my readings are 52, 56, I think it just reflects being relatively fit, I suspect. There's a lady at the front, just second from the aisle.
Thank you. Could I just ask about this research that's taking place at
You
Nottingham?
certainly can. So Harry is going to come up and tell us a little bit about it. So Harry is one of our research doctors. Come over here. Come and take the podium, and he'll tell you all about it.
Hi everyone, I'm Harry. I'm one of the registrars at the hospital. I'm sorry for intruding on your blood pressure talk, but thanks for asking about the research we're doing. Essentially, we're looking to trial a new therapy that's non-pharmacological, so not drug-based, and non-invasive, so it doesn't involve a procedure technique called ischemic preconditioning to lower blood pressure in people aged 65 to 85. In short, it involves using a device to reduce the blood supply to your arm for very short periods of time. And we think essentially it mimics exercise in activating some of the body's recovery pathways. And we hope that that might reduce our blood pressure. And if we could do that, that would be a great thing to have in our sort of armory of things we can use against high blood pressure. So on a lot of the seats, I put a flyer for the research study, and it's got my email address on it. So if anyone wants to know more about the study, then I've got a much more detailed participant information sheet that I can email back to you. And I'll leave it there for tonight because I don't want to take up too much of your time. But if anyone is interested, drop me an email and I'll send you an information sheet and we can talk on the phone if you want to know a bit more. Thanks very much.
So, of course, research is key to working out what to do next.
Can you tell us, please, the why we're asked or recommended not to eat grapefruit juice when taking these wonderful pills?
So the grapefruit juice is for the simvastatin. So the grapefruit juice is fine with most of the antihypertensives, but it's simvastatin that you're asked not to take grapefruit with, which is a cholesterol-lowering medication. And because of the way that grapefruit juice is metabolised, it has a similar pathway to simvastatin, so it can change the level of it. And that's the only statin that it does it with.
Can I just ask about the electronic blood pressure devices? What's sort of a lifespan of one of those? Should you consider replacing it if you've had it for, I don't know, more than 2 years, 3 years?
That's a really good question.
Or do they need is there a way of getting them calibrated?
So you can get them calibrated, and it sounds fancy calibrating, but basically you take it to somebody else who's got a machine and you check they both provide similar readings. So you probably need to do it on an annual basis, either with a blood pressure cuff at the pharmacy or at your GP's surgery. Now they should actually, depending on how much hammering they get, they should last quite a long time. I've had mine for, I might have had it for 10 years now. You made me think about that. Perhaps all those blood pressure readings are all incorrect. But that's a very good point, isn't it? They're pretty robust. Harry, do you know any answers to that? The lifetime of a blood pressure machine.
Yes, so they vary by manufacturer, but you can get them calibrated at pharmacies. So which means they've got their blood pressure monitors updated regularly, and they can kind of test yours and make sure it's calibrated properly. So
Do we have any questions from the teams? Oh, they're all quiet because we do have a virtual audience, apparently. So,
thank you. You didn't mention anything to do with cholesterol. I know with people raised cholesterol levels are put on statins.
They are. So I was trying to keep to hypertension, and hypertension is a massive subject. So when you're looking at your overall health, knowing your blood pressure is good. Knowing your cholesterol is also useful. Now, whether you should be on a statin as primary prevention depends a little bit on your overall cardiovascular risk. So it's probably, I could do a whole talk. Shall I come back next year and do cholesterol? Yeah, okay. And then the year after that we'll do diabetes, shall we? And then we'll come back and see what everybody's blood pressure is the year after that and see how we're all doing. So there is certainly evidence that getting your cholesterol lower reduces cardiovascular risk. There is more evidence in secondary prevention than there is in primary prevention. So primary prevention means before you've had a stroke or a heart attack. Certainly if you've got hypertension, you should have your cholesterol measured and then risk stratified. Now, after stroke, we use very high dose statins because there was a big study called the Sparkle study that showed a 12-statin 80 produced reduced risk by about 40%. Now, these are all relative risks rather than absolute. But actually, again, there needs to be a nuanced approach because not everybody's cholesterol is the same. And your cholesterol in your blood doesn't necessarily reflect how much atherosclerotic disease you've got. And some people are really sensitive to statins and the cholesterol comes down really well. Some people need much bigger doses. So again, the genetics will help us. But I think a good message that you said, know your blood pressure. If it's high, know your cholesterol. Are there any other questions? Well, thank you. Oh, there's another question, Colin.
Relating to high blood pressure and cholesterol, could cholesterol bring on high blood pressure?
Can cholesterol cause high blood pressure?
Narrowing the arteries?
So it is quite complex, the narrowing of the arteries. So often the small arteries are more that they get stiff and pruned. Cholesterol often will contribute to large vessel atherosclerosis, which can lead to hypertension, but it's the small blood vessels that are more important with the hypertension. Often if you've got one, you've got the other. But cholesterol acts itself does not cause hypertension as a direct link, but it is part of it, if that makes sense. And because all of it, you know, when you look at your package of cardiovascular risk, sadly it's just not one thing, it's a whole group of things together, which is why your intervention is, you know, your diet, it is your exercise, you know, it is your blood pressure, it is your cholesterol, it is making sure you've not got diabetes. It's the whole package together.
Yeah, sorry, another question. I apologize for keeping everybody. Someone who may have had a cardiac emergency, is it common practice to put them straight onto the blood-lowering medication?
So if you've had a heart attack, when you've had a heart attack, there are a number of medications that have been shown to have benefit post a heart attack, whether you're hypertensive or not. So it is standard treatment after a heart attack to be given a beta blocker, and that's to do with remodelling the heart and reducing the risk of further events afterwards, and ramipril as well, an ACE inhibitor. So there are certain conditions where tablets that we use for blood pressure in certain cardiac conditions are used as well, even if your blood pressure is normal. So after a heart attack, that's one indication. If you've got heart failure, where often you've got low blood pressure because you can't produce output, often you're on lots of blood pressure medications that lower your blood pressure, but your blood pressure is not high. And they'll be used for a different reason, which is about the remodelling of the heart and supporting the heart failure.
Because sometimes I say you just give them medication and you may not get a full explanation because it gets too involved. You just say, take this.
Yeah, no, and it can get very involved. I talk about my mother-in-law, Nana Babs, and she had hypertension for many years, and she was very hypertensive, and she was on 4 medications. But then she had a heart attack and had heart failure. So then she was put on more medication that was for heart failure, but not taking in board the hypertension side of things. And then she had atrial fibrillation and a pacemaker, and then actually her blood pressure just sank. And actually she was better if we stopped everything. So that question about hypertension tablets for life, well, maybe not, because things do change throughout life. And I think we have to be vigilant and be prepared to change and look at things again. So if you're on a tablet and you think, well, I'm not quite sure why I'm on this, then go and ask the question. And don't be afraid to ask for your numbers, your kidney function tests, your HbA1c, your cholesterol levels. They are your levels, so you should know them. And any doctor or clinician that says you can't have them, needs reminding that it's yours, not theirs. Thank you very much, everyone.
Right, so it's back to me. I'd really thank Jess so much, and Harry, but particularly Jess, for a really interesting session. I know I've learnt a lot. We will be putting the talk on the website for the hospital, and also we'll include the slides in case there's anything in the slides you want to look at again. So that will all be included. I'd like to thank the staff who've stayed on late tonight to help us, particularly Claire, who's done an awful lot towards this event, and she's been a star, so thank you, Claire. Okay. Our next talk is Thursday, May the 2nd. It's Head and Neck Cancers with Mr. Bindi Sahota and Associate Professor Elizabeth March. It's going to be a really interesting one. If anyone's used car parks, we have got some get out of jail free cards from either Claire or myself. Hopefully they'll work. If not, just press the button and tell them that you've been on a health talk and you've got a free card, and you should get out the car park for free. And thank you all very much for coming. It's been a really good night, and thank you for everything you've turned up with. Thank you.